Good evening, everyone. Thank you for your patience. Here we are for another excellent journal club. We have some very special guests from more than across the pond, I guess, in Australia with us tonight. We have Dr. Miriam Welgampola and her team there, as well as Dr. Alison Young, who's also a part of the team there in Australia at University of Sydney. And I'll let Dr. Welgampola start her introductions there first.
Hi, Helena. Thank you so much for inviting us. We're very happy to have with us part of our team, and starting with Belinda Kwok, who is our senior audiologist and doctoral fellow, and Alison Young. Sorry, Alyssa Dybel is a doctoral fellow. Sorry, it's hard to forget. And this is Dr. Miranda Morrison, who's all the way from Switzerland visiting us for 2 years, and Dr. Diego Herrero, who's a neurologist visiting us from Chile. So thank you so much for the invite.
Wonderful. No, we're excited to have you all for sure.
Yes, and I used to work with the crew in Australia as well, but I have since moved back to British Columbia, Canada. And so, I'm an audiologist and clinical practice manager at an audiology clinic on Vancouver Island. So that's what I'm doing at the moment.
Beautiful. All right. Well, we're very excited about tonight's topic. So let's go to our slides here. And tonight's topic is about Meniere's disease. So you all, I'm sure, are all too familiar with clinicians feeling challenged with the diagnosis of Meniere's disease. Is it overdiagnosed? Is it underdiagnosed? How should we be diagnosing it? So this article is really lovely, and so I appreciate your effort to help us try to, as I like to say, untangle this mystery of Meniere's disease a bit. So before we get into the article, I'm going to go ahead and just briefly cover a little bit of anatomy. So inside our ear, we have a part of our system that handles balance and processes our movement. This is the vestibular apparatus. So that'll be the star of the show here. And then nearby, certainly also involved in Meniere's disease, is some hearing structures, particularly the cochlea. With all that input from the inner ear, that information goes to the brain and gets processed and integrated ideally with other information from our other senses, our vision, our sense from our joints of where we are we leaned or straight? Every joint has some sensation there, proprioception we sometimes call it. So all of that information is supposed to be integrated. And so patients often ask me, as a vestibular physiotherapist, why do I have these sensations? What's going on? I'm sure you all have had some patients, express their frustration or confusion about this. And so, I think that speaks to some of what we're going to cover in the article as far as why, just because a patient has a given diagnosis, that they don't necessarily present identically. So Meniere's disease, as it is described in the article, as a peripheral vestibular disease, presenting with fluctuating oral symptoms, fullness in the ear, tinnitus perhaps, or tinnitus, I don't know how you guys say it. I've heard it both ways. Hearing loss, and recurrent spontaneous vertigo lasting between 20 minutes and 12 hours. As far as why this is happening, what's the true pathophysiology, there seems to be still some debate, as I understand from the article. So one theory that's mentioned, Resner's membrane rupture theory, seemed to kind of be implied by the article that perhaps this is not as well supported as we would like. So there's the second theory that's also described, this drainage or physiologic valve theory. And instead of me trying to read this out, I'm going to go ahead and ask just one of you. So how about Dr. Welgampola, you'll start out for us. If you could just explain this drainage theory for us about Meniere's disease.
So basically, the hypothesis is that there is an accumulation of fluid in the cochlea, the vestibule, the semicircular canals, and this accumulation of fluid can really go one way or another across the receptors, just covering the receptors of the semicircular canals, of the utricle, and the passage of the fluid and the accumulation of the fluid can cause pressure changes and changes in the drainage pathways. And those fluctuations can actually result in either an irritative or a recovery picture of in terms of peripheral vestibular disorder. The membrane rupture theory was different in that it was a sporadic event leading to a change in a leakage of the endolymph into the perilymph compartment, resulting in changes in the ionic composition. More recently, there has been a shift towards people believing that it is more the drainage theory that is more likely to be closer to reality. And even more recently, there are people who have undertaken very prolonged event monitoring compared to what Alison and I have done, and demonstrated that what we call the irritative and recovery phases happen multiple times, as many as about 5, 6, 7, 8 times, so that we might even have to change the nomenclature for these attacks.
That's really interesting. So, with that being said, and this may be the $1 million question, but perhaps Alison, Dr. Young, you could tell us what, if anything, do we have as far as what's kind of kicking all this off? Like, I know there's been some theories about genetics, environmental, just give me your little, 1 or 2 second blurb about what you think about that.
There is no consensus. There doesn't seem to be, even now, unless Miriam, you have any other updates in the literature, but there can be a familial history, but so much of the time there is no history of Meniere's disease in the family in our clients, and there does not seem to be, as far as I know, anything that for sure can kick it off. We do know we can see certain, I would say a small percentage of those demonstrating Meniere's-like symptoms, maybe post-trauma, post-cochlear implant. This is rare, but we do think that possibly some sort of endolymphatic hydrops can occur after some sort of trauma. But honestly, I don't think that's the most common presentation. I think it is just a spontaneous event. Miriam, do you, in your clinic, feel like there's any history that would preclude someone or make someone be more suspicious of Meniere's versus migraine?
There are theories and theories. There's theories of autoimmunity, theories of viral infections. So the 5 major contenders are trauma, autoimmunity, viral infections, inherited causes. Then there are said to be people who from birth have structural abnormalities that lend themselves to hydrops. None of these are proven. Yeah. And then, of course, there's the possibility that what we call hydrops, what we call Meniere's disease, is just a clinical syndrome with multiple etiologies.
And it's true of some studies that they will show even a slice of a normal group of individuals will have a small amount of endolymphatic hydrops with absolutely no symptoms whatsoever, just in big normal control studies. So that's unusual as well. So just to keep that in mind, there's a wide range of normal and those that are outside that bell curve will have these symptoms, but it's probably a continuum.
Very, very true, isn't it? Yesterday, I think Miranda and I, and we were discussing how one of our collaborators, Dr. Julia de Gleitschek in Switzerland, presented a study where she looked at people who were waiting for cochlear implant, and she demonstrated cochlear hydrops in these patients, completely asymptomatic. Just people with age-related hearing loss, but completely asymptomatic.
Right, and this has echoes as a physiotherapist of some of the research I'm sure you all are aware of regarding things like scans of the spine and how they can have abnormalities or degenerative changes, but some patients have tons of pain, and some with kind of the same level of changes have no pain. And so I think this speaks to the body's complexity, which is both cool and challenging. So, so looking at Meniere's disease, we look at kind of a symptomatic diagnosis to an extent, this kind of criteria, looking at this low to mid frequency sensory neural hearing loss, some possible asymmetric vestibular test results, kind of fluctuating test results from a vestibular standpoint, and even a hearing standpoint sometimes as well, as I understand. And they are looking for at least 2 episodes to try to call it Meniere's disease. And there has been proposals of stages where at first there's more vertigo and strong vertigo and hearing loss and tinnitus, and then it kind of goes into less vertigo, hearing loss is increasing, and there's actually eventually less vertigo, more hearing loss, and more problems with balance. So I'll go back to whoever you want to speak on this, Miriam. What would you say, is this kind of a classic pattern, or does it vary? What's your experience there as a team?
So, as you was just itemizing those things, I thought, wow, that's a nice practical set of criteria. It's very similar to what we use in clinic. But of course, it's very different from the Bharani criteria or the AAOHNS criteria, which will say, okay, they don't take into account your vestibular test results. They will say, hearing low frequency hearing loss, an episode of vertigo lasting, 10 or 20 minutes or longer. And the vestibular function tests really don't play an important role in it, and certainly ictal examination doesn't. But in clinical practice, for those of us who see people with, is this Meniere's disease being the question, what you describe now is a very practical approach. Number one, is there spontaneous vertigo? That is what by definition long. So 20 minutes is a reasonable duration. Is it or isn't it time locked with oral symptoms? And is it or is it not associated with appropriately lateralized vestibular test abnormalities? Is it or is it not associated with reasonable ictal nystagmus that is fast and horizontal and direction changing? So those are the go-to questions that we try to answer in order to give the patient an estimate of how likely is this to be Meniere's disease. But obviously all these questions have to be proven by, have to be evidence-based, and these are anecdotal. We just approach it in a very anecdotal fashion. But I think we're coming closer to the time when some form of vestibular test abnormality and some form of nystagmus abnormality should enter our criteria for Meniere's disease. But we're not there.
For sure. So looking at that, I had read in an article, which I think is referenced down in the little corner there, Sobi et al., that there were some kind of vestibular staging as far as what structures seem to be affected chronologically or over time, starting with the cochlea and the saccule, then moving on to, as the disease process progresses, I believe, the utricle, and then lateral canal, and finally the anterior and posterior canals. Are you familiar with that information? Is that an article you've read, Dr. Young?
No, not particularly that article. I mean, we do see, I suppose, just from what we've seen in the clinic, I don't think particularly I would look at sort of a progression of different things, but we might look at severity of many things together. So even just starting with, obviously the cochlea will be the easiest one to test first. And you, like, as Miriam said, the Bharani criteria is that you actually do need to see that low frequency hearing loss or fluctuation on an audiogram. So I would agree that that's the first easiest and most logical place to start. We do end up seeing VEMPs affected. as to when they can be affected, I think they can be affected quite early on. And again, I think it probably depends on what stage you catch them in when you're testing them. But certainly the longer someone has been suffering, I would say the more likely you are to see progressive asymmetries on vestibular testing in the clinic. But you have to be mindful that even when you are testing things like, let's say they get a transtympanic ECOG test, electrocochleography, which doesn't happen too often, but even then, you know, if they are having a day when they've been taking a lot of their medications and they don't have a lot of fluid buildup in their ear, that test could actually be negative when they do clinically sort of seem like they've got Meniere's. So you do have to take normal hearing tests with a grain of salt as well. And that's part of the issue. And that's probably why, you know, the Barani criteria and those, they tend to err on the side, not quite yet, of including the end organ tests, because they can be, especially earlier on, erroneously normal. But you do have to sort of keep testing them over time and catching them in different phases of, and by phases, I don't mean over time. I just mean phases in having an attack today, feeling well tomorrow, because there is going to probably be different fluctuating function on those tests.
Got it.
Yeah.
So is the dream to get someone who's in an active episode in for testing?
Yeah, so that's pretty much the gold standard. What we find is that people who are having, who do end up having a diagnosis of clinically definite Meniere's disease, if you can catch them during an episode, their eye movements, their nystagmus, as Miriam mentioned, it'll be spontaneous, it'll be horizontal, and it will be very fast. If you compare someone who's having an episode of vestibular migraine, which for many intents and purposes can have a very similar case history, very similar symptoms, what we have found is that they can have nystagmus eye movements, they can be sick and ill, but their eye movements are significantly slower than those with Meniere's disease. And, you know, we did have some outliers where they would kind of overlap, but anecdotally and even the, you know, when we run the statistics, the Meniere's sufferers have significantly faster slow phase velocities to their nystagmus, and they almost never show, you know, vertical nystagmus, and they don't show, you know, if you do a roll test, their nystagmus won't change directions the way someone with vestibular migraine can do. So yeah, it's like most illnesses, probably if you can see them when they're active. Of course, that's hard because they feel awful and they can't leave the house when they're ill. So that's the problem.
Thus, your home device. We're getting there. At any rate, I kind of summarized some testing that, you know, you might try to do, or a clinician will try to do with someone to try to rule in or out Meniere's. And one of those is called the V-HIT, which hopefully everyone watching is somewhat familiar with the head impulse test. So the V-HIT is a video version. It's instrumented. It can catch, you know, much more subtle corrective eye movements or saccades than you might be able to see kind of without the instrumentation. And, you know, it seems like it might be abnormal or it might be normal depending on when you're catching them, was kind of the gist I got from the article. And then VEMPs, particularly OVEMPs, looking at the utricle, seem to be enhanced during an acute episode, this kind of irritative phase that Miriam mentioned, but then some reduced VEMPs or absent VEMPs perhaps later on in the disease process. You mentioned ECOG, which can certainly be abnormal, but again, not always from what I understood. And then there's also kind of the challenge of it being a little bit invasive. And it sounds like it's not as common of a test, you know, for clinicians to maybe be familiar with or to be doing regularly, we'll say. And then there's VOG, which would be just viewing the eyes. VNG implies that you're using some eye tracking software, which you all just kind of did it in stages. You kind of got the VOG information first and then analyzed it later to get that eye tracking information for specific data. But be that as it may, and we're going to get more into this later, but there's can be horizontal nystagmus towards or away from the affected side, depending on when you're kind of catching the moment, I guess you'd say, of the Meniere's flare and process, if you will. And then I thought it was interesting, and I just wanted Dr. Welba-Gampola to speak to this, or anyone on her team there. The downbeating nystagmus had been observed in some cases of bilateral Meniere's disease. And most people see by downbeating, they're thinking, oh, brain, central, Chiari malformation, or, something, cerebellar maybe. So what could you say about the reason that might occur?
Okay, so I have to be very truthful here, Helena, and say I've never seen downbeat nystagmus in bilateral Meniere's disease. First of all, the luxury of looking after someone with bilateral Meniere's disease is rare because they are quite rare. Then seeing them in the middle of an attack is also even rarer. So the truth of the matter is I personally haven't seen it. And in our study, we haven't studied and documented someone with bilateral MD having downbeat. But Alison did record multiple patients who, in the one recording, had irritative nystagmus going over to paretic nystagmus, and the in-between phase, they showed downbeat. So I don't know whether that's what is being reported in studies. It's possible, but I just haven't seen it, so just can't comment on that.
No, that's still very helpful information, actually. So,
Alison, what do you think?
No, that you read my mind. That's what I was thinking. I mean, if your eyes are going to be continuously having the fast phase changing from right beating to left beating, they have to get there somewhere. So yeah, what we saw was a right beating, and then it will just, like a clock, like the arms of a clock, literally go like that over a minute. So you do end up seeing the vertical. If you catch them and that's all they recorded, you would actually see vertical nystagmus. But I haven't seen sustained vertical nystagmus in a Meniere's patient myself, but that's not to say strange things happen. Yeah.
Anything's possible with nystagmus, that's for sure. All right. So thinking about these patients and how your approach was quite excellent. You all, tried to do this recording at home to catch them during these attacks because, as was mentioned, it can maybe be difficult to see them in clinic during an attack. So the patients were taught how to record a routine of eye videos on a portable device, a VOG, goggle, so to speak, monocular in nature, but good enough. Gets the information that I think you all needed. And, with that kind of diagnosis of Meniere's disease, I wanted to just kind of highlight, we already kind of talked about these criteria or kind of characteristics we tend to see, but there is also kind of a category of probable Meniere's disease, and I just wanted to ask about that. So for those who don't have hearing loss, this is because they maybe had an episode or two and kind of got their hearing back as the high drops episode resolved, so to speak. Is that the concept, Dr. Young?
Yeah, so basically in the early stages, I mean, it will cause hearing fluctuation. There's no question if it is Meniere's. The problem is that these hearing fluctuations can be very short, and who knows how often it's fluctuating. It could be going up and down. We don't even know, multiple times during an attack, probably slightly before. We did ask patients to try to do hearing tests, but again, it's very difficult, and that's the biggest problem. And that's often why they say this: if you have clinically probable Meniere's disease, but you haven't just gotten that hearing test at the right time to show that hearing loss. And so it's important just to kind of ask them, do you feel that fullness, that hearing fluctuation at the time? So it's tricky to catch, because if they go to their audiologist a day after the attack, their hearing could be back to normal. So it fluctuates probably quite a bit during the early stages. And then as the disease progresses, it will become more stable and it will decline over time. So it's easier to catch it later. But of course, as we all know, we're trying to diagnose them early so we can, get Dr. Welgampola to prescribe the correct treatment plan. So it's tricky, yeah.
And what does over time mean? Can it vary months, years? Like, what are we talking here?
I'll let Miriam handle that one, but it can really vary. And there is a spontaneous remission sometimes where they have what looks like Meniere's disease. We get a bit of treatment going, and then we honestly don't see them for a few years. So, Miriam?
Yeah, agree. It can be months, it can be weeks, it can be years. And the longer you stay the older you get, I should say, the older you get, the more variations on the theme you discover. There are some people who had their first attack 20 years ago and nobody knew what it was and presumed Meniere's disease. And then you're seeing them the second time. And now, lo and behold, they have declared them. So it can vary a lot. But the majority of our patients would have a course that runs over months to years. But there are some who run over weeks and say goodbye and never turn up again and never have an attack again. And there's a small proportion who run over decades.
All right, so a lot of variation there. Got it. That was what I was wondering. This is difficult to see, but forgive me, I just pulled it from the article quickly. I wanted to ask a couple questions about the clinical history and cardiovascular risk factors for the patients that you all studied. In particular, your article does a nice job of trying to kind of do this really challenging thing of trying to differentiate migraine or Meniere's, and then of course we know there's a group that does indeed have both. So for this kind of section here, there's some discussion about gender, which, in migraine tends to be more female, but in Meniere's, as I understand it, it tends to be 50-50. Have I got that right, Dr. Young?
I would say absolutely, yeah.
Okay, and then Dr. Welgampola, as far as these features, so there's discussion about headache and visual aura, sensitivity to light and sound. Those numbers, except for maybe, I guess, arguably headache was a little bit stronger, were a little low in the sense that it's not as common in Meniere's as in migraine. Is that accurate?
That is correct, but in the individual patient, that doesn't help you.
Right.
Because of the very high prevalence of migraine in the community, there's a high chance your young female patient who's coming with the first attack of Meniere's might actually have migraine headaches as well. And I think the prevalence of migraine headaches generally in the Meniere's population is higher than in the average population anyway. So you just have to bear that in mind. It is Fair. Headache prevalence is quite high among Meniere's sufferers. Maybe it comes to the forefront because the Meniere's is a physical stress and therefore makes you declare yourself if you have the right genetics for migraine.
Makes sense. All right, and then I guess we'll circle this back to Dr. Young about the tinnitus, however you like to say it. Unilateral kind of more common, though not everybody. Bilateral, not strong at all. What are the thoughts on that?
Referring to tinnitus in Meniere's disease?
Yes, correct.
Yeah. Yeah, tinnitus is a byproduct of Meniere's disease, and Meniere's disease is usually unilateral. You do see some, it's quite rare, as Miriam already pointed out, it's quite rare to have bilateral Meniere's disease. Sometimes you can have Meniere's disease in one ear and then years later develop it in the other ear. That's probably one of the more common ones. So yeah, the unilateral is a real tip-off for Meniere's if you're trying to compare with this. Tinnitus is very common in everybody as we get older. So you do have to sort of again, just bear that in mind. But it's just that it's so starkly unilateral in the ear that is affected in Meniere's disease. And so if someone's sort of waffling and, oh, I get some ringing, I'm not sure what ear it's in. Usually those with Meniere's disease, they know which ear it's in because it's very dramatic and it's just in the affected ear. So, yeah.
Got it. Fair enough. And then similarly, although not as strong on the numbers as the tinnitus, is the oral fullness, which again had that kind of, if you're going to have it, if you have Meniere's disease, it looks like you're describing it unilaterally and never in this study bilaterally. Is that right?
Yep. Again, it's just that everything is going to be pointing to the one ear. And some people have a hard time describing what they're feeling because there's a lot going on, especially if they're having an attack. So some people who have hearing loss for other reasons, there is a sensation of fullness or muffling because they have hearing loss, and it's can be confusing. So you do have to, again, take things with a grain of salt. And it's more about having symptoms be really lateralized and getting them to just describe whatever they can about that one ear. Sometimes but some people will just say, oh, the first thing I notice is my ear feels like it's full of water, then I have an attack. And other people will say, oh, I've never noticed the fullness, I've only noticed the tinnitus. So it's just sort of that one-sidedness is what to look out for.
Very good information. All right, so I had to feature your device here, Dr. Wilgampola. Lovely swim goggle with some camera, we'll say, infrared video camera, no doubt, attached there. And I just wanted to ask you, it's very clear in the article, this is, kind of done for the research study. It's not something that's commercially available. And you might be aware that there has been a company in the past that did kind of an iPhone version for home recording that I'm aware of. So, is it your hope that maybe not this exactly, but there will be something for folks who have these kind of difficult to catch symptoms to have something to do at home? I know some folks just do it with their cell phone. What do you think is ideal? Because I think there's some challenges, of course, to patients trying to record their own eye movements during episodes with a cell phone because, they're, maybe kind of feeling something. It sounds like you had pretty good success with this. I just would like your reflections on what the future of kind of trying to sort out causes of, this kind of intermittent type of symptoms that can be hard to see in clinic or to kind of identify what's going on clinically when we get an appointment 6 months later.
So look, it would be wonderful if we could produce an inexpensive device that is within the budget of the ordinary person that can be purchased in a place like a pharmacy and used and maybe even recycled. This device was designed by Professor Hamish McDougall. He's a researcher at the University of Sydney. He designed the first device about 15 years ago. And then our hospital's biomedical engineer custom made some specifically funded by the research project. But it has stopped right there. But it would be really nice if it could be manufactured. There have been subsequent companies that have manufactured near identical devices, but the price is so high that it is not within the budget of any individual, and that there seems to be a terrible unfairness to that. So I think the key is if some device that is based on the video Frenzel principle can be made available by anyone worldwide, and it is available to the average human, that we want. And that was the good thing about the Dizzy Doctor, the one that you were referring to. They managed to make it available for a price of about a little over $100. And I think that's the kind of bracket that we are looking at. Because someone who's dizzy doesn't want to spend their entire income on purchasing a device that will catch it.
Fair enough.
which is only a diagnostic device. Yeah. So no, we haven't progressed in that regard. It's something that's always that we're thinking about. That I think it would be a really worthwhile exercise for dizzy people worldwide.
Definitely. All right. Well, and then there's the topic that I don't even want to address, which is the regulatory aspect of all of that as well, which is there's another, I don't want to say barrier, perhaps, to some folks trying to address this need. It doesn't mean it can't be overcome, and I agree. It's something that would be good to see what we can do about. So, that being said, you all used your device and had the patients sitting in neutral, I would say, forward gaze, and then you had them lie on their back and then on each side for, kind of limited time frames, getting video recordings every 15 minutes from symptom onset when possible. And, as far as the patient's symptom reports, in your study, 100% were actually reporting spontaneous episodic vertigo, and most reported kind of what we consider to be a true spinning type vertigo. And then there was some proportion that reported more of what I would consider to be a rocking, swaying, this kind of mal de débarquement type presentation. And then you all did lots of tests. You tested hearing. You looked at caloric, so we're putting cold or warm water, I believe you all used. Was air is also an option, I believe, and kind of tried to identify any canal paresis. And Dr. Young, please confirm for me if I'm not mistaken, that's testing the horizontal canal specifically. Is that correct?
Yeah, each horizontal canal separately for the for the calorics. Yeah.
Awesome. All right. And canal paresis was defined as, I believe, as a pretty much a standard of a difference between the two sides greater than or equal to 25%. And then I have to admit, since I'm not an audiologist, since the slow phase velocity seemed very important, I did my best effort to try to explain it in my best terms. So I am excited for you all to either correct me or just say it's pretty good. Whatever it is, I'm not attached. I just want to make sure that the group who's watching can also understand if you're not as familiar with what slow phase velocity means. So this is us, kind of measuring the eyes with eye tracking software, and we want to know kind of how far the eyes traveled. I'm making an nystagmus for everybody here. So how far the eyes traveled in a direction. With a nystagmus, it's going to be quick and a little bit slower, quick and a little bit slower, although even the slow phase can be pretty fast. It's just slower than the faster one as far as a direction over time. And so we're able to calculate velocity, and that gives us a degrees per second. Degrees is the distance in kind of a circular motion, if you will, and then the time in seconds, pretty clear cut. So a slow phase velocity that is a bigger number, so 30 degrees per second, would be faster than something that would be 10 degrees per second. How am I doing?
Perfect.
Pretty good.
Not bad for a physiotherapist who does not do these tests and tries to understand them.
It's you don't even have to delve too deeply in it. I'll try to. So basically, there's the fast phase is sort of, think of it as the direction it's pointing to. So left, it's left beating because that's the way it's going fast. Mm-hmm. And then it's just that slow pull back. The brain wants the eyes to face this way, so it's pulling it back. That's the slow. And so we describe nystagmus direction, fast phase, and then the slow phase is sort of the measurement of speed. So it's those two different ones. And honestly, the higher the speed, like anything, the higher the speed. So
right.
The eyes aren't supposed to be moving like that.
The worse the patient probably. Yeah, well, the worse the patient probably feels, right? That's kind of
that's all you have to know. So you don't have to, you don't even really have to measure it. I mean, usually you can see with your own eyes,
how brisk it is.
Yeah, I'm sure you've done calorics, and you can see you can see with your own eyes how fast someone's eyes are moving. And if you're looking at someone and you can barely see a drift, you can think to yourself, well, that's a pretty slow phase. So
For sure.
you can kind of, yeah.
Gauge it, right? But you all had a number line on your diagnostics at the end here, which I'm not getting to yet. So that's why I wanted to cover that for everybody. So you also checked VEMS in most of the patients. You did taking the horizontal canal, lateral head impulse test on most of the patients, and a subset you did go ahead and do those LALPs and RORPs, so however you say them, those checking the posterior anterior canal function with an impulse test as well, and then the ECOG on a few. And then I just wanted to pull out real quick, because I love BBBV, not because I want people to have it, because I can usually fix that one, so it's very exciting when you find it. You're like, oh, something I can do something about for sure. And I'll throw this one to Dr. Welgampola. So you found in not the majority by any means, but in a few you found some BBV. So like any good clinician, you took care of it for them. And I just wanted to ask you, should someone be curious as to why, sometimes it was in the affected sides. So the bilateral person, it was on both, and in the unilateral affected side, you had 2 patients, but there were 2 that had BBV on the non-Meniere's ear. Any rhyme or reason to that? Is just kind of because BPV is so common? What do you think?
I wonder whether it's just because BPV is so common. Yeah. We have, however, in the past had people who presented consistently with BPV in one ear, and later on they demonstrate Meniere's in that same ear. And then you wonder whether that was the first indication of something being amiss. It was secondary BPV. However, BPV is so common.
For sure. So it could have been one of each. One's headed towards Meniere's on that side, and one's just a random BPV on that side. Fair enough. All right. Just a little curiosity to me. All right, great. So here are your findings. I tried to summarize them as best I could in a table, because I love tables. So we've got the V-hit, and you had some, findings of folks who had, signs of decreased function on the Meniere's side, which makes sense, but not everybody had that V-hit come up as being abnormal on that Meniere's side, if you will. And then hearing, there was an asymmetric increased threshold for 100%. So I would just say this was a little surprising to me, because I know we kind of mentioned, so I guess all of these weren't maybe as early. Kind of why was that, do you think, the case, Dr. Young?
Sorry, what was the question? Why do you think
that you had 100% that found increased thresholds in asymmetric in 100%, but yet we talked about how maybe they might not always have abnormalities on their hearing test early on. So
yeah, well, we had the benefit of seeing these patients many times. And so we had, for the study, we had the benefit of, I literally, like if I had a patient, and they're our patient anyway, so we're seeing them quite often, and they were in the study, I would just test them over and over and over again. And we did give them a really nice home hearing test kit that's available commercially. And we would get them to test themselves at home as well. So we were like going to catch them,
Got it.
Not every clinic has that luxury. So because it was, yes, 100% of Meniere's patients will have hearing loss. And we had the benefit of seeing them over and over again. And that's the only reason you can do that, because honestly, if we just did a hearing test just on the first clinical visit, I bet you we would have missed it in 50%, especially if it was early Meniere's. You really have to keep testing them, unless, sometimes you get a patient and they've had Meniere's for a while and you see them kind of in the middle of their disease. They bring you an audiogram with the hearing loss on it, and it's kind of a slam dunk. We would use that in the study. So any documented hearing test with that hearing loss was used. So we were lucky in that regard.
Got it. So this kind of brings to mind, and I think maybe Dr. Welgenpaul can speak to this, our desire to have home devices, whether it's home VOG or home hearing test or both, to me is the strongest for those folks that have decreased access, whether that's they live somewhere that's far from a lot of centers, rural, whatever you want to call that, or just kind of other reasons that they would have decreased access, more homebound type, if you will. Those kind of situations. So I see you nodding emphatically. So is that kind of your thought there?
Completely. I think the more remotely they are located, the better candidates they are. And or if they're disabled and they can't get to your clinic. Yes. We found that in recurrent spontaneous vertigo, it was particularly helpful because your BPV, you will catch it. You can tell them the very next time you wake up in the morning with this, do come. And there is enough time to do that. But with the recurrent spontaneous vertigo, the attack is gone before we manage to get to you. So that is also a strong indication.
Good point. Good point. All right, I'm going to kind of breeze through the rest of this. So we mentioned ECOG. We did find a lot of high drops in these folks, although I would just say it sounds like sometimes, in this group we knew they had Meniere's disease, but it sounds like there's sometimes where this ECOG could be positive if someone had mild high drops but no symptoms. So just kind of putting that in the back of the head on my end. And then the calorics had some asymmetries, but it wasn't 100%. But 100% definitely had that ictal spontaneous nystagmus, almost always horizontal. And I wanted to highlight something you highlighted in the article as well, this kind of puzzling finding of normal lateral V-hit gains with significant lateral canal paresis with caloric testing in patients with Meniere's disease, this kind of dissociation rate you all talk about. So I'm just going to throw that to Dr. Welgenpaul. You want to address that briefly?
Nobody really knows the reason for that. There are different hypotheses. Lee McGarvey from our hospital hypothesized that, well, maybe there is sort of turbulent flow within the horizontal semicircular canal. That's responsible for the canal paresis, but it doesn't affect the hair cells. Therefore, the hit is still normal. There have been theories about which type of hair cell these two tests represent. Statistically, Alison will be able to give you a better idea. I think there was still a minor asymmetry in the horizontal canal gain, even on the V-hit, but not to the degree that you could pick it in the individual person. So let's say we put together 100 people, we could tell, but the gain asymmetry would be something like 0.9 in the unaffected ear, 0.84 in the affected ear. So both are falling strictly within your normal limits, and you can't possibly call it out. The other thing is that the V-hit is not as bad as we think if we catch the person ictally. There have been some of our colleagues, Dr. Ben Nam, who actually did V-hits on a couple of these people ictally and demonstrated reduced gain and catch-up saccades while they were having the attack. So there might be abnormalities that we haven't yet tapped into in the V-hit that may reveal themselves in the future.
Yeah, and I'm just going to encourage folks who do more of a bedside exam, don't have a V-hit, and are doing a red hit impulse test, that just because those look fine on both sides absolutely doesn't mean that that person does not have Meniere's disease. So don't get hung up on that as being your sense of, oh, yes, they definitely have Meniere's, or not if you're like me and don't have a V-hit. So, this kind of back and forth with the nystagmus, I think it's a lot to take in. We're kind of getting tight on time, but what I want to just ask is, for a person who's, having a patient in front of them with seems to be kind of a recent or, kind of current in the moment attack, don't be surprised if you see a nystagmus, where you think you might know what the good side, bad side is, but kind of if the patient's in front of you and you're not doing calorics, you just kind of have them in front of you bedside, if you will. um, the direction of the horizontal nystagmus by itself in that moment may not tell you the affected side. Is that an accurate kind of picture there, Dr. Young? Do you agree as well?
Yep. Long story short, it's going to change direction. And just as Miriam pointed out, there's new research showing that it might go at different times. And there's honestly, at the moment, there's no rhyme or reason as to how long it'll stay in one direction. That's even just from our study. It did seem to have quite a quick phase, direction change rather, close to the beginning of the attack. But the variety of time differences between a direction change that any patient would record was all over. I tried to make some patterns out of it, but honestly, if you see a direction change, that's pretty damning, but it might be Meniere's. But again, just as you rightly pointed out, let's say you thought it was in the right ear, and maybe the nystagmus is ipsiversive or the other way. Don't say to yourself, oh my goodness, I've diagnosed the wrong ear. It could just be in one phase or the other. So it's more the symptomology in one ear and then fast horizontal nystagmus in general, just to make it an easier package, sort of.
I like the hacks. All right, good. And then, not to just keep going on about migraine, but we just had Dr. Jeffrey Sharon, yes, I think I'm saying that right, last month on about migraine. And so I pulled this slide from that talk just to kind of remind folks that folks with migraine also can have tinnitus. So again, I think sometimes people get hung up on the fullness or the tinnitus. That definitely means it's Meniere's. And that by itself, again, definitely not enough. And even some hearing loss can be seen in folks with migraine, which may or not be related to their migraine, but just kind of don't kind of get led astray, by symptoms. I feel alone sometimes are a little bit tricky. So you all found that the ictal nystagmus, so during an episode with the slow phase velocity greater than 12 degrees per second and a caloric canal paresis of greater than 25%, would allow you to correctly separate Meniere's disease from migraine, vestibular migraine, with a sensitivity and specificity of 95 and 85% respectively. So we're hopeful that will help others in the future to try to make a more definitive diagnosis for Meniere's disease. You all went into some interventions. I know folks like to hear about interventions. I hope a lot of folks who've heard about Meniere's disease have heard about the low-salt diet. What do you actually specifically recommend, Dr. Welgampola? Like below a certain milligrams per day? What do we got?
So you're talking to someone from a very relaxed part of the world, people who really enjoy their food and don't like counting sodium. So we don't tell them to stick to a certain number. The three things I tell them are, number one, do not add salt at all in cooking. The second thing is try to avoid the high salt culprits. And these are cheeses, cured meats. And over here in Australia, there's a product called Vegemite that is really popular. Vegemite, and no sauces and no pickles. So we say avoid the high salt culprits. And the last thing we say is try to read the food labels. So again, here in Australia, the Meniere Society has randomly picked out of thin air the magic number of 120 milligrams per 100 grams of food. And we say try to stick below this. The one food type that people have great difficulty with is bread. There are very few bread types available in this country that will have less than 120 milligrams per 100 grams of salt. So some of our patients will choose to bake their own bread. It's just more out of difficulty rather than out of a need to specifically stick to that guideline. So those are the three things I tell them. Don't add salt, avoid these 5 food types, read the labels. But we really don't encourage them to count the numbers because that becomes like a career. And that's pretty sad. We just try to push Meniere's back into where it belongs, which is in the very periphery of your life.
Fair enough. All right. And there's lots of, if necessary, medical interventions past medications, which I kind of breezed over that section. But suffice to say, I had pulled this from an article. It's kind of a relatively good guideline, perhaps, of how it was interesting that this one particularly said that you can actually arguably put 80% of patients in remission with kind of these more conservative approach of diet and diuretics or beta histine, things like that. Do you agree that that's what you have also found in your practice, Dr. Wilgampola?
Completely. I'd say roughly about 90% of our patients have made one visit for the diagnosis to just one initial consult and one follow-up consult, and that's it. They say goodbye to the clinic after that. There's about 1% of them who will be perpetually in trouble for a period of about 6 months, and they'll have the full gamut of treatments, including intratympanic steroids, gentamicin, labyrinthectomy. I'd say at any given time, there's one person like that in clinic, and it's almost as if they're holding a baton and then they pass it over to the next person. But right now, we don't have such a person in clinic, right? We don't have a Meniere's patient who is in trouble right now.
All right.
Such but in any given period, there's one. So that's how rare it is to be in deep, deep trouble.
Excellent. Excellent. And to know that Meniere's is already relatively rare, that's pretty encouraging. So as far as vestibular therapy, I'm going to give my 2 cents on this if you all don't mind. We cannot prevent Meniere's attacks with vestibular therapy, in case anyone's wondering. However, can we address symptoms as far as dizziness, balance between attacks, and certainly kind of in the spirit of what I'll call management for safety, things like that? Absolutely. I think there can be a role. And then after intervention, if they were to go to the point of an ablation via something like intratympanic gentamicin injection or something, absolutely very valuable, like any hypofunction, frankly, really highly valuable to have therapy. And they've shown in this study, at least, that the benefits last even 8 to 10 years after therapy. They do better on balance and things like that. So certainly a good message there. And then as far as treatment for hypofunction, I've covered this in other talks, so I'm not going to go into in depth. I would encourage folks, if you're not familiar with the clinical practice guidelines for vestibular rehab after vestibular hypofunction by the APTA through the vestibular subsection under the neuro group there for the American Physical Therapy Association. Those resources are free online to anyone. You do not have to be a member. So you can explore those clinical practice guidelines as a physiotherapist. I always screen for BPPV if I have a patient who's coming in with at least a theoretical diagnosis of Meniere's that's on a script from someone. I don't always know what kind of testing they've had to confirm the Meniere's piece, but I always check for BPV. That's an easy fix if I find it, and you don't want to leave that untouched. After that, if you are finding presentation like a hypofunction, certainly we can help with that and balance train, as well as vestibular rehab with gaze stabilization exercises and things of that nature. The tinnitus is probably too much to get into now that we're running over time. I do not treat that, but I understand that audiologists sometimes try to assist, both by addressing hearing loss as a way to provide good hearing, and then also some other interventions that different folks try, including addressing kind of stress management, cognitive behavioral therapy, things like that. So I'll give you 20 seconds to add something on that, Dr. Young.
Tinnitus therapy and treatment is a very multifaceted type of treatment. You need to look at cognitive behavioral therapy, audiological rehab. So if there's hearing loss, putting amplification on the ears can sometimes help. There's tinnitus maskers, and it's just a really ongoing process that should be individualized. But it's a complex issue for sure.
All right. Well, perhaps someday I'll do a full hour on that, but not today. All right. So, in conclusion, the statement at the end of the article is that a mix of testing would benefit a patient that may have Meniere's, including testing hearing for sure, possibly doing VHIT, VEMP, caloric tests, and ideally checking for that spontaneous nystagmus during events if possible. At some point, hopefully we can get something more standardized for that going, as well as a standardized questionnaire, which might also help to draw out some of those highly reported features that you all mentioned, and that was discussed in the article as far as symptom reports that tend to be more likely to present in someone with Meniere's disease. And I did do a bit of a social media post, posterior fossa arachnoid cysts sometimes try to mimic Meniere's disease. Luckily, they're highly rare, so much more rare than Meniere's disease, as I understand from the article that I read. But just be aware that even things that look like Meniere's or look like migraine could be something else. And this is why, although imaging, an MRI of the head, would you say, for example, is not always necessary, if something's very vague and kind of unusual and has maybe some other neurologic signs of some sort, we don't want to kind of assume migraine. We don't want to always assume Meniere's just based on history. So I put up some resources for folks. Y'all can screenshot this, those who are watching. If you ever want to get a hold of these lovely clinicians and researchers, they are at the Balance Center, clinic, near the University of Sydney, as I understand. And you have a lovely YouTube video that you all did for a group in India, I believe, ictal characteristics of common and uncommon vestibular disorders. So y'all can Google that and check that out on YouTube as well. So we're ready for questions. Let's go ahead and go to that. All right, Doug Bozeman is first here. For those with an onset of Meniere's complaints after cochlear implant, are there still hearing changes perceived by the client? And are there specific testing that could be done outside of nystagmus and subjective symptoms? I'm going to volley that to Dr. Welgampola there.
Or to Belinda.
I'm going to give that question.
Oh, great!
Well, Belinda's doing her PhD on this topic, and
Wonderful.
she'll give us. Yep.
So actually, with that question, it's a bit hard to say. So definitely, we have seen patients who've had a cochlear implant and then presented with Meniere's like symptoms of like episodes of spinning vertigo lasting hours. With the hearing, because we now know that the hearing is through the cochlear implant, they will find that the hearing goes off and they'll need to go to their audiologist to get it remapped. When they go to that setup, often if the audiologist runs a impedance check, which is looking at kind of how well the electrical signal is running to the nerve, there have been occasions where they found that the impedance have skyrocketed. So that gives you an idea that something is happening inside the inner ear. Occasionally, in a very small subset of patients, we have seen that they've developed Meniere's in the contralateral ear, and they will report that the hearing fluctuations are coming from there. So yeah, that's it in a nutshell. We've only seen this in a small subset of 25 patients in which we were able to also record exactly the ictal home VOGs. So whether it happens in a wider group we're not sure about that. It's likely it does, and it hasn't been captured. But from our clinic, we've actually been able to document this in around 25 patients with the ictal home recording. Not all of them had, we didn't end up, diagnosing all of them with post-CI endolymphatic hydrops, but a good proportion of them were most likely post-CI endolymphatic hydrops.
Ah, those poor patients, that they don't have enough troubles, huh?
Mm-hmm.
All right.
And-
Well, I think, Doug says thank you. And I normally throw in a few more questions, but given that we are a little shy on time, I will wrap this up. But I just want to say this was fabulous. I know it's going to be really helpful for a lot of folks who watch this in the days and weeks and months ahead. So I just want to thank both your team, Dr. Gualgampola, yourself, and of course, Dr. Young as well, for joining us and for your research and your ongoing work is so valuable to these patients that we all, I think, care a lot about and want to help. So thank you for your time.
Thanks for having us.
Thank you for the invite.
All right, everyone else, we'll see you at our next journal club, and thank you for joining us.
Thanks, Stephanie.
So how's the PhD going, Belinda?
It is reaching the end.